Hi, my name is Justine and I'm a nursing student on 6B. I will now present to you a focused assessment about one of my patients. My patient was a single 53-year-old Caucasian female. She was A&O times 4, full code, and on contact precautions for MRSA. She was homeless and temporarily residing at a motel, struggling to find long-term housing when she was admitted to the emergency department at UMHS on November 7, 2014 for hematemesis due to esophageal varices. She was discharged on November 14, 2014 to her friend's house in Sterling Heights where she was placed on hospice care. The patient's primary diagnosis was decompensated hepatitis C cirrhosis. The patient had 7 hospitalizations at UMHS since May 2014 for chronic liver failure, worsening ascites, edema, nausea and vomiting, and various infections including E. coli, C. diff, and MRSA. The patient's history of present illness included hepatitis C, cirrhosis, chronic liver failure, MRSA, a lesion in the right lobe of her liver, portal hypertension, jaundice, hepatic encephalopathy, esophageal varices, anemia, splenomegaly, coagulopathy, thrombocytopenia, hyponatremia, hypothyroidism, anxiety, chronic lower back pain, arthritis, and osteoporosis. The patient unfortunately passed away on November 19, 2014 from hepatitis C and end-stage liver disease. The patient's vital signs were as followed. Temperature 97.6 degrees Fahrenheit taken orally, heart rate 92, respiratory rate 18, blood pressure 119/64, pulse ox 93% on room air, height 5'8", weight 109 pounds, BMI 16.6. The GI tract is the first pertinent system for this patient that I will discuss. I first interviewed the patient about her GI tract. Her medical history for this system included hepatitis C, cirrhosis, chronic liver failure, a lesion in the right lobe of her liver, portal hypertension, jaundice, hepatic encephalopathy, esophageal varices, anemia, and splenomegaly. She had a family history of hyperlipidemia and GI ulcers on her mother's side. Her surgical history included paracentesis and an IR transjugular intrahepatic portosystemic shunt. The patient had a history of alcohol and drug abuse. The patient stated that she no longer drinks and that her last drink was in 2004. Before she quit drinking, the patient said that she drank 4 to 5 times per week and had 6 to 7 drinks each time. The patient also admitted that she used to do cocaine and heroin, which was most likely how she contracted hepatitis C. The last time she used these drugs was in 1979. The patient had a history of chronic lower back pain since she was 40 years old, that she described as stabbing and sharp and typically ranged between a 5 to a 10 out of 10 on the pain scale. The patient also experienced occasional aching, pressure, abdominal pain from her ascites and stabbing, sharp liver pain only when touched. These acute types of pain started occurring earlier this year in May 2014. Her pain was typically aggravated with excessive movement and worsening symptoms of her ascites and liver failure. The patient alleviated her pain by taking analgesics such as Tylenol, morphine, and Lidoderm, and she also used a heating pad under her back when needed. After these pain treatments, the patient typically denied feeling any pain or a 0 out of 10 on the pain scale. The patient was not experiencing any abdominal pain at the time or demonstrating guarding behavior when discharged. In addition to her pain medications, the patient was also taking laxatives such as Dufalac and Senecot for her constipation and increased serum ammonia levels, diuretics such as Lasix and Aldactone for her ascites, antiemetics such as Zofran and Phenergan for her nausea and vomiting, the antibiotic ceftriaxone for her MRSA infection, and Prilosec for occasional indigestion. In regards to the patient's diet, she said she ate 10 to 12 small meals per day at home and only ate half to 75% of her meals in the hospital. The patient was underweight and recently experienced severe unintentional weight loss. She lost 8.8% of her body weight in the past month due to decreased appetite, inadequate nutrition, lessening ascites, muscle atrophy, stress, and anxiety. She had no dysphagia, adenophagia, food intolerances, or allergies. Her dietitian recommended that she start drinking Carnation Instant Breakfast Essential Shakes and start taking a daily multivitamin and vitamin D. In regards to the patient's I's and O's, her output was about twice as much as her intake, resulting in a negative net balance of 710 milliliters. The patient experienced severe nausea and hematemesis upon admittance and during most of her stay, but she did not have any when discharged. The patient said she usually had one bowel movement per day and experienced occasional constipation. She said her last bowel movement was earlier that day and she had 3 bowel movements the night before. Therefore, after laxative use, the patient did not experience any constipation. She also did not experience any pain when defecating, and she did not have any diarrhea. I then performed a physical assessment on the patient's abdomen. When I inspected the patient's abdomen, I saw that it was symmetrical but distended due to her ascites. The skin was smooth and dry but jaundiced, which was consistent with the rest of her body, with striae around the lateral borders. The umbilicus was inverted, midline, and in the center of the abdomen with no redness or drainage. She had an old healed incision with stitches in the lower left quadrant of the abdomen from her last paracentesis. There were no visible bulges, masses, or surface movement. I then auscultated her bowel and vascular sounds. I heard irregular, high-pitched, active bowel sounds in all 4 quadrants, and I did not hear any bruits or venous hums. Next, I lightly palpated her abdomen. I did not deeply palpate her abdomen because she said it felt tender when touched, especially over the liver, and she also had an enlarged spleen. Her abdomen was firm and tender, and her organs and aorta were non-palpable. The respiratory tract is the second pertinent system for this patient that I will discuss. I first interviewed the patient about her respiratory tract. The patient had no history of lung disease or allergies and was not taking any respiratory medications. The patient had a smoking history of tobacco and marijuana for the past 38 years. She smoked 3 cigarettes per day and smoked marijuana 2 to 3 times per week. She said she tried to quit but was never successful and that she was interested in quitting but did not have enough motivation to do so. She said she often relied on cigarettes and marijuana in times of stress and when she was in pain. The patient had an infrequent productive cough. She was coughing up small amounts of blood, but mostly phlegm, when discharged. However, she said she was coughing up larger amounts of blood when first admitted. The patient had a pulmonary functions test done, which found that she experienced shortness of breath and fatigue during strenuous activity, but did not experience shortness of breath or fatigue with most activities. The patient demonstrated that she was independent regarding all her ADLs, such as bathing, dressing, transferring, toileting, continence, and feeding. The patient was given an incentive spirometer to use at least 10 times per day, which she said she would continue to use after discharge. She also used a nasal cannula at night with 2 liters of oxygen. Next, I performed a physical assessment on the patient's chest. When I inspected the patient's chest, I found that her skin was jaundiced, which was consistent with the rest of her body, with no signs of lesions, redness, or swelling. Her chest was symmetrical in size and shape, with a normal 1 to 2 AP to transverse diameter. Her respiratory pattern had a normal rate and rhythm of 18 breaths per minute, and her pulse oximetry was 93% on room air. Her effort of breathing was unlabored and quiet. Both sides of her chest expanded and contracted evenly, and she did not show signs of accessory muscle use. When I palpated her trachea, I found it to be midline and non-tender, and she did not have a thyroid gland due to her thyroidectomy. When I palpated her anterior and posterior chest, the patient did not report any pain or tenderness, and I did not feel any swelling or crepitus. When I auscultated her breath sounds, I found that they were clear bilaterally over the anterior, lateral, and posterior lung fields. A third pertinent system I would be interested in assessing would be this patient's neurological system. According to Filippo, it is important to assess brain function in a patient with chronic liver failure. The liver is responsible for removing toxic compounds from the blood. Therefore, during liver failure, the liver is unable to remove these toxins, such as ammonia, which then causes them to build up in the blood and affect brain function, resulting in neurological and psychological alterations, such as hepatic encephalopathy. This is relevant to my patient because she did in fact suffer from hepatic encephalopathy. She said that when she did not take her Dufalac, she noticed a deficit in her short-term memory. The final pertinent system I would be interested in assessing would be this patient's peripheral vascular system. According to Schub and March, it is important to assess the peripheral vascular function in a patient with chronic liver failure. Liver diseases, such as cirrhosis, can cause portal hypertension, which then increases the pressure in the smaller esophageal veins. This increased pressure ultimately can cause the esophageal veins to rupture, resulting in varices. This is relevant to my patient because she was admitted to the hospital for hematemesis due to esophageal varices. And that concludes the end of my patient-focused assessment. Thank you for your time.